I am a doctor.
I am a data collector.
I'm a pharmacist.
I am a clinician.
I am a counselor.
I am a nurse.
When the AIDS pandemic hit, we had information, but with COVID-19, we were never ready for the real impact.
We are frontline workers regardless of a pandemic.
We had to become resilient. That was our biggest motivator.
We are health providers.
We are health providers.
We are health providers.
We are health providers.
Bi alsamadi mënatuñu nangu ñun doomi Afrika ngeen di ñu xool ak benn bët.
Pay attention to me, my name is Nana C. It's my history, the African in me. Since before I could read, my brain fit to feed. Had my feet on the ground for my Fulani seed.
Wake up, good morning. This is Dakar calling. L'Afrique est en ligne. This is Senegal calling. Wake up, good morning. This is Dakar calling. Youssou est en ligne. This is Africa calling. Lo jàppoon na nga ko ba. Maa ngi fi tey, maa ngi fi ëllëg. Bés bu ne day dellu si. Na nga ko gëm, la ko tey.
Holding on to all the little pieces. I'm with you, so preaching positive thesis. Walking over tears falling down like rain. But still I have a little something in my brain.
Wake up, good morning. This is Dakar calling. L'Afrique est en ligne. This is Senegal calling. Wake up, good morning. This is Dakar calling. Youssou est en ligne. This is Africa calling. Wake up, good morning. This is Dakar calling. L'Afrique est en ligne. This is Senegal calling.
All the stairs.
We'll get through this, we've been through so much more. Keep the faith, singing, tomorrow will come. Be strong, be brave. Together we will rise.
Aduna bi alsamadi mënatuñu nangu ñun doomi Afrika ngeen di ñu xool ak benn bët.
Pay attention to me, my name is Nana C. It's my history, the African in me. Since before I could read, my brain fit to feed. Had my feet on the ground for my Fulani seed.
Wake up, good morning. This is Dakar calling. L'Afrique est en ligne. This is Senegal calling. Wake up, good morning. This is Dakar calling. Youssou est en ligne. This is Africa calling. Lo jàppoon na nga ko ba. Maa ngi fi tey, maa ngi fi ëllëg. Bés bu ne day dellu si. Na nga ko gëm, la ko tey.
Holding on to all the little pieces. I'm with you, so preaching positive thesis. Walking over tears falling down like rain. But still I have a little something in my brain.
Wake up, good morning. This is Dakar calling. L'Afrique est en ligne. This is Senegal calling. Wake up, good morning. This is Dakar calling. Youssou est en ligne. This is Africa calling. Wake up, good morning. This is Dakar calling. L'Afrique est en ligne.
Good afternoon, everyone, and especially to our satellite teams. We hope you've had a fantastic and productive morning, and a very big shout out to you all. Welcome to Africa Cafe 2 on the third and final day of the PATA 2021 Summit. I can't believe it's nearly over, as it feels like we've only just started. My name is Agnes Ronan. I am the head of programs at PATA. I'm excited to be your chair for this session today. Today's theme, as you know, from this morning, places you as health providers at the center of our conversations, providing you all with a platform to engage and interact with your peers from across the region and policymakers, and to share not only our successes, but also the challenges you face in translating policy to practice in your, as you deliver services on the front line. So this particular session is entitled Curbing the Silent Crisis, Strategies to Mitigate Burnout Among Health Providers. And it places a spotlight on health providers' well-being, especially now in the context of the pandemic. Some of you will remember that at the outset of COVID-19 in May last year, PATA conducted a survey among its network of health providers, the results of which formed the foundation of much of our key advocacy messages and activities over the last year at various national, regional, and global platforms. So now, a year later, just over a year later, we've gone back to do a temperature check and currently have a second survey underway. So if you are a health provider listening now and you have not seen the survey yet, please do visit our homepage where you'll find the link to the survey so you too can have your voice heard. In fact, I'm hoping that one of my colleagues will post the link to the survey in the chat box as we speak. So this session, we will hear both collective and individual voices from our health providers across the region on the impact of COVID on their daily lives. We will then hear about some of the efforts that have been made to mitigate some of these impacts, as well as some practical examples and tips on how to facilitate implementation of such interventions. So to take us through this session, I'm pleased to say we have a great lineup of speakers. So let me introduce you to our speakers. Our first speaker is Dr. Fileuka Ngakongwa. Dr. Ngakongwa is the PATA country representative in Tanzania, and she's based in Dar es Salaam. Dr. Ngakongwa will provide a sneak preview into the preliminary results of the second PATA Health Provider Survey that I just mentioned earlier. And this will set the scene for us for this afternoon's session. Our second presentation builds onto Dr. Ngakongwa's presentation and will be led by the trio from the incredible Hey Baby team at Mzansi Wako. They're from the University of Cape Town and the University of Oxford. And the three presenters will be led by Shanae Glinsky. Shanae is the Fieldwork Project Manager, and she'll be supported by Bongiwe Saliwe, Assistant Project Manager, and Babalo Ataleni, Senior Research Assistant. Their presentation provides reflections of public healthcare nurses during the first wave of COVID-19 last year in the Eastern Cape province of South Africa. Their work was more qualitative compared to our survey, and therefore they will share with us real voices of those at the brunt of COVID in health systems. So we will hear from the voices of our frontline health providers and peer supporters directly from their own words. Our third speaker is Professor Jackie Ho. Professor Ho is a neuropsychiatrist, this is a mouthful, sorry. She's a neuropsychiatrist, head of division of consultation liaison psychiatry, and co-director of the HIV mental health unit at the University of Cape Town. Professor Ho will speak to some of the initiatives they've been running at the Groote Schuur Hospital here in South Africa during COVID to keep up the morale for frontline health providers. Prof. Ho will highlight how and why some of the traditional approaches and strategies were not sufficient in providing the much needed support to their colleagues. And she will share the model they adopted and some practical tips for implementing such alternative approaches. Their story is very well articulated in a letter published in The Lancet last month, and you will find the letter on our website or in our resource hub. Please do take a look at it. And lastly, we will hear from Dr. Graham Hodinott, research psychologist and co-investigator at the Desmond Tutu TB Center at Stellenbosch University here in South Africa. Dr. Hodinott will share results of the extensive work conducted by the Panagora Group to explore existing debriefing platforms and mental health experiences of health providers in South Africa. Their work provides key recommendations and practical tools to facilitate implementation and for strengthening existing support platforms for health providers. So lots of goodies available to take away from this session. Please visit our Linking and Learning Hub to find some of the resources that I've just mentioned. Please do also read the speaker's bios, as my introduction, I don't think, does justice to their wealth of experience. So just before we delve into the presentations, just some usual housekeeping. During the presentations, please feel free to post comments in the chat box and questions in the Q&A box. And if you can, please state who your question is directed at. After all the presenters are done, we will give all the speakers an opportunity to respond to your questions. Any questions that are not answered live will be addressed through the Q&A channel. And so now, without wasting much time, I will hand you over to our first speaker, Dr. Ngakongwa. Thank you, and please enjoy the presentations.
Yes, thank you, Agnes, and good afternoon, ladies and gentlemen. And as Agnes said, I'm Dr. Ngakongwa from Tanzania, representing PATA. And I'm here to take you through PATA COVID-19 health provider survey, which the main focus was exploring the impact of COVID-19 on the health provider. So in the face of the growing COVID-19 crisis, PATA continues to be concerned for the health and safety of those on the front line of health service delivery. So this survey was done in two phases. The first phase was in April 2020, where 188 health providers from across sub-Saharan countries participated in the survey. And the second phase, this is the follow-up phase, where almost 215 respondents from 15 countries across the East, Southern, and West and Central Africa. We are targeting to reach more than 612 frontline health facilities across 24 countries in Africa. So the survey had different components, and the first component was caring for COVID-19 patients. And here, what we, the results was more than 50% in one way or another have cared patients who, or clients who were suspected or diagnosed with COVID-19. But on the other side, with regards that more than 50% who were exposed to the clients who suspected or diagnosed with COVID-19 cases, 45% were only feel safe, sufficiently protected from COVID-19 at work. And looking again on the access of enough personal protective equipment, only 52% have the access of enough PPEs. But in addition, again, 92% always wear the mask. And this could be a good sign of wearing the mask, but on the other side is a kind of a change of habit. We usually were not wearing the mask, and since for the past from last year to now, we see that we constantly wear masks at work. It may be stressful even to other healthcare providers as well. Next slide, please. So the other component that we're looked at is the COVID infection and impact on work. Here is what the results were. 23% of respondents missed work because of they were infected of COVID-19. Further to that, 42% reported missed work because of they were possibly exposed to COVID-19 and had to isolate. And further to that, 35% of respondents said they missed work because of they did not feel safe or protected from COVID-19. So looking at this, we see most of the healthcare providers were not at work. Individually, they were stressed out with anxiety, worry of being sick, worry of being getting the COVID-19, and on the other side is the number of healthcare providers were reduced in our clinics, which also has huge impact on huge burden on the work at the facility. And so with this creates a stress environment for both the ones who were exposed and the ones who were also working at the facility. Next slide, please. So how do they feel about COVID-19? Mostly were negative. They feel the COVID-19 is very close, 86%, and 80% they think about it, they're preoccupied about the COVID-19 most of the time. And 61% they feel extremely stressed about it. And also they feel about 49% they feel this COVID-19 spreads quickly. So this, you can see how much amount of stress is built up among our healthcare providers. Next slide. So with experiences of stress, going back again to number of health providers who felt safe and sufficient protected, was only 45%. What about 55%? How do they feel about it? So it's kind of a build-up anxiety on them, on about of how am I protected or am I not protected? Again, 52% only they have access to PPEs. What about 48%? And further, it's again 92% wearing mask. And this is the constant throughout your day, you wear mask. It can be stressful for other healthcare workers as well. Next slide. Looking on the bigger picture, again, health providers are largely stressed about their own health and the health of their family and friends when it comes to their biggest concern about COVID-19. 35%, they're worried about their own health. 30% family, worried about the health of their family and friends. There was increased risk of sadness, increased level of anxiety. So with this, it builds up the stress, and the experience for this, it's more on the fear of contracted COVID-19 or the fear of dying, the fear of transmitting COVID-19 to the family member or to the significant people. They feel stressed about the loss of significant people, their colleagues, the family members, and it can be traumatic at times. And with the buildup of this anxiety, we are worried about the future, the aftermath of this the crisis of COVID-19. So because of the increased preoccupation of and the fear of COVID-19 and its effect. The next slide, please. So in summary, the well-being and mental health of health providers are also affected in that many of them personally know people that have died of COVID-19 related causes, and this excludes patients and clients. So 59%, I personally know many people that died of COVID-19 related causes. Could be close relative, could be colleague, could be friend as well. And then 40%, many of my friends and family have been infected of COVID-19. Next. So to summarize, very few respondents felt safe and sufficiently protected from COVID-19 at work. There's still a need to ensure that frontline health providers have access to enough PPE. Health providers are largely stressed about their own health and the health of their family and friends when it comes to their biggest concerns about COVID-19. These concerns resulted in health providers feeling increased level of anxiety for themselves and others. And lastly, the well-being and mental health of health providers are also affected in that many of them personally know people that have died of COVID-19 related causes, and this excludes patients and clients. So lastly, I want to encourage if any health providers who haven't yet completed this, please, the link to complete this, you may get it from, and it's the survey is in English, Swahili, French, and Portuguese, and you may get the link from the Linking and Learning Hub, and also I think we'll share the link later. Thank you.
You cannot be the nurse you used to be. Reflections of public healthcare nurses during the first wave of COVID-19 pandemic in the Eastern Cape province of South Africa. Presented by myself, Shanae Glinsky, Fieldwork Project Manager.
Baba Lwadaleni, Senior Research Assistant.
On behalf of the incredible Hey Baby team, and with thanks to all the nurses that participated. We are part of a team called Hey Baby. What does Hey Baby stand for? Helping empower youth brought up in adversity with their babies and young children. Our aim is to assess resilience promoting pathways for adolescent parent families living in adversity, including young parents living in resource-constrained, HIV-affected communities. Our baseline ran from 2017 to 2019 with 1,046 mothers, some HIV positive and some HIV negative. Follow-up began in 2020 and is ongoing. Hey Baby asks two groups of research questions. What puts adolescent parents and their children at risk of disadvantage, and what services can help adolescent parents and their children? Our nurse study began at the start of the COVID-19 pandemic in response to a social need to find out what was happening for healthcare workers and get some information on what was happening for adolescents within the healthcare pathways. The way we did this was by doing qualitative, semi-structured interviews with nurses in the Eastern Cape who were familiar with the Hey Baby study. The aim was to understand the experiences of healthcare workers during the COVID-19 pandemic in order to identify ways or strategies that could help them navigate the disruptions caused by the pandemic, but also identify as ways or sort of niche areas where support could be provided, and support that could provide enough of a platform for them to continue to service the needs of their patients. The way we did this is by creating an English and isiXhosa translated tool with a little bit of English in between. We did 6 months of online training because we had to shift to completely remote data collection. We used 3 incredible research assistants who did phone calls, who did interviews over phone calls, and in the end completed 13 interviews with nurses, and which we then analyzed for various themes. The themes will be discussed by Babawa. Thank you.
Our findings from the nurses experienced focus on three things. The first one was resource constraints, which included shortages of basic resources, rapid depletion, and delayed restocking of COVID-19 related equipment, additional strain due to staff shortages. These shortages of stock included EPPEs, which led to nurses having to reuse the PPE and find alternatives. The already existing challenges that we know that nurses had even before COVID-19 and stressors that nurses faced were made more intense by the COVID-19 pandemic. Many nurses were off because they got COVID and were in quarantine, which affected the rest of the nurses and their workload. And the second finding was about psychosocial burdens. These included daily dilemmas and internal conflicts associated with the pandemic, which affected their health, their well-being, their ability to deliver services to the patients. Healthcare workers and nurses have always experienced high stress levels, but COVID-19 made this stress much more worse. Nurses reported feeling physically and emotionally drained, and some nurses compared themselves to robots. They felt like machines that even when trained, they had to continue or keep on going because it's like they did not have any feelings. They were not regarded as people with feelings. They were expected to go on and go on and go on. And the stories nurses told us suggested that they felt caught in between helping patients and doing what their job required versus the fears of getting the virus and taking it back to their families. And the last finding, which was adaptive responses, showed nurses' willingness to meet the needs of the patients, including responses for young patients living with HIV. Things like taking initiative, being available for their patients 24/7, ensuring that medication is provided. Examples included forming a response committee to respond to issues arising from COVID-19, tracing patients whose treatment was interrupted. Some of the nurses took personal time to seek out patients that they saw that loved ones have not been collecting their medication anymore, and then provided personal contact information to patients 24/7 to the community, also using the services of local caregivers to deliver medication.
Recommendations falls under two categories. The first one is holistic support of healthcare workers, which include continued sustainable concrete forms of psychosocial support, encouragement alongside emotional and practical support from hospital management. Nurses reported no psychological support from having to find their own ways to cope. This highlights the need for real support. The second recommendation is finding innovative ways to ensure adolescent youth living with HIV continue to access healthcare services. Nurses are uniquely placed to understand the dynamics of their communities. One way of doing this is task shifting. Example, community healthcare workers tracing defaulters and delivering medication. This may reduce workload and COVID-19 burden on healthcare facilities. Stories from nurses show how they are using community workers to support patient care, This process is something that could be invested in, and if encouraged, could decrease the burden on nurses. Conclusion. As the COVID-19 pandemic evolves and continues to create challenges for healthcare service delivery, it is essential that nurses are supported in ways that avoid burnout and empower them to meet the needs of their patient. Thank you so much. And thank you to our funders and our nurses. Thank you.
Hi, so I'm Jackie Hall, and I'm speaking to you from Groote Schuur Hospital. I don't have any slides, and I'm going to be sharing with you our experience, or my experience, as a mental health care professional, a psychiatrist, working on the COVID frontline. And so that would be what we have experienced here at Groote Schuur Hospital. So we cared for patients with severe COVID pneumonia. Our context was that we had high flow nasal oxygen units as well as ICUs, and we separated our high flow nasal oxygen units from our ICUs, and we were running 3 high flow nasal oxygen units, and ICUs expanded to include about 6 different wards. So Groote Schuur saw an enormous amount of patients with severe COVID pneumonia. I don't have the final stats from the end of the 3rd wave. By the end of the 2nd wave, we saw 8,000 patients alone through those units. And it has been an incredibly traumatic time for our healthcare workers because we really were caring for some of the sickest patients with COVID pneumonia, requiring, ICU level and high care. And unfortunately, that means that we experienced many, many deaths throughout our experience of the COVID pandemic, which now spans 3 waves. So I'm going to share with you my experience, which is, it's different. What we did here at Groote Schuur in terms of how to support healthcare workers was quite different, because I took a very hands-on approach, and about a month into the 1st wave, I decided to work in the high flow units and in the ICUs. So really what happened was that I became a part of the frontline healthcare worker team. And so I'm just going to share with you the kind of build up to that decision and why it turned out to be the right decision, and how we came to kind of understand the importance of me being integrated into the COVID frontline team. So these are the teams that are caring for the sickest patients with COVID pneumonia in a very intense and high turnover context. So I'm kind of taking you back now to the beginning, because I suppose really what this is it's a story of why I ended up on the COVID frontline, and in effect why I've stayed and why I will be returning at the end, when the 4th wave comes. So in the beginning, sort of in March 2020, we sort of tried to prepare ourselves and our healthcare workers for what was to come. As the news of the effects of the pandemic in Europe reached South Africa in early 2020, we began to deal with the anticipatory anxiety about what was to happen in South Africa. And of course, there was lots of worry that the situation here would inevitably be worse, in view of the HIV prevalence being about 28% among South African women and 14% among men. So initially we responded to requests from different departments to meet with medical colleagues with whom we'd worked closely in our consultation liaison service. We met informally and collegially in group settings, but we realized very early on that providing skills for coping or resilience training or workshops on burnout, etc., were not sufficient. There was an abundance of such information and such advice available on social media at the time. Some of it was useful, but mostly really quite familiar to our colleagues. What's problematic about this approach is that saying to healthcare workers that you need all of these skills unwittingly was blaming the individual for not managing themselves and their stress and pathologizing them rather than acknowledging that the trauma was real and affecting an already traumatized healthcare system systematically. What became acceptable to the doctors eventually was a contained space, a group, where they were able to share their experiences and their anxieties. But that only happened after I joined the team, after I became part of the frontline healthcare worker team. As we know, for doctors in particular, to be vulnerable and to feel overwhelmed may be hugely stigmatizing. What was important for me was to normalize these reactions as an appropriate response to real trauma, to dissipate the stigma to some degree. What we came to understand is that a reality-based fear of contagion and death during the pandemic was superimposed on an implicit worry that overwhelming and unacceptable feelings could be spread to others and could potentially be toxic or fatal to others and the health system. The fear of the pandemic is superimposed on living in a violent society. South Africa is a violent society where healthcare workers are experienced in seeing the impact of violence on patients and the healthcare system. Part of our job was to provide a space to allow that fear to be expressed safely. So key to our intervention was when I took the decision to work directly with the healthcare workers and particularly with the doctors in the high flow nasal oxygen wards and ICUs. It was only after this relationship had been established, after I'd become a part of the team, that the groups could happen. And importantly, not just only happen, but for them to be useful. And the reason why is because at the moment that I became part of the team, I was dealing with the same trauma and the same anxieties myself. I was bearing witness to the same suffering and deaths that they were. The most difficult to access doctors were the doctors working in the high care and intensive care units. Prior to me working with them on the front line, I called and made offers for help. Their responses to me were, they were very grateful that I was concerned about them, but they would say things like, you're a scarce resource, others need you more, and we're fine. But this all changed when I worked in the high care wards and experienced for myself the trauma of working in those units. The team had many stories to share of their trauma. In effect, I was bearing witness to the trauma that the team was faced with daily. But I was also being unconsciously tested to see if I was able to survive the trauma and manage their emotions. We came to see that the negative responses to my offer of help in the beginning of the pandemic from a distance, as opposed to being with them and openly sharing their trauma with them on the wards, represented two sides of the same coin. Our colleagues were experiencing the unimaginable and the unspeakable. The only way they could begin to speak of what they were going through was for me to have an embodied experience of what they had experienced. It became clear that the doctor's past reticence to accept help was also that they had no time to think, felt that asking for help themselves was beyond their capacity, and in fact, felt it beyond their capacity to identify which patients needed emotional support from myself. But I was able to recognize this inability as part of the traumatization itself. But my shared experience, my working on the front line with the team and sharing the same traumas with them, made it possible to shift the model of helping our colleagues from a traditional group therapy model, which was rejected. They rejected this model, to being a collegial support space for sharing trauma. It became possible for them to safely express their emotions in the groups because I had been through the same trauma. They said a number of times, we can only talk here. We can't even talk to our partners, even though some of these partners were also medical professionals, because no one can understand exactly what we've been through. And you understand because you are there with us. You are one of us. We understand from the literature that trauma can isolate one from those who have not been through the same experience, but it also binds us together. Those that have experienced the same trauma become connected. An intense bond develops between those who've shared the same trauma. The downside, unfortunately, is that we became separated and isolated from those who weren't experiencing what we were experiencing. So the function of the groups was to make a space where people could feel safe and connected and not alone. The aim was not to provide a set of techniques for coping, but rather to put these experiences, provide a place where we could put these experiences into words, and thereby addressing the isolation and the stigma that trauma inherently brings. It's not just the sharing of the same trauma that makes a band of brothers and sisters. It is also the processing together, processing that trauma together, that makes a band of brothers and sisters. The groups were accessed by a wide range of clinicians across the traditional medical hierarchy. It included interns, senior consultants, heads of divisions, clinical units, up to professorial level. All attended. The sessions often extended beyond the appointed end time as people stayed milling about, wanting to talk. We were also given an enormous amount of positive feedback regularly, saying how helpful it was just to talk about what was happening to them. We also believe that what was most helpful is that we didn't try and fix everything, or tell colleagues what to do. It is well established that in medical socialization, there is a pressure to become an expert, the demand to fix difficult situations and to remain in control. Failure and anxiety may be experienced as humiliating, shameful, and something to be hidden. But my embodied experience of a situation in which control was impossible and the solutions far from perfect laid the groundwork, we believe, for our being able to work with our colleagues. We came to see that the many sets of tools, such as resilience training, which have been developed to help medical personnel cope, though they do have their place, may be experienced as positioning these colleagues as incompetent and lacking, when in fact the primary issue is not clinician incompetence or even mental health challenges faced by clinicians, but a situation which is objectively novel and challenging to manage. Once the impossibility of the task is recognized and experienced, then it seemed to us there is space to think. In reflecting on our ongoing work with medical colleagues, which will extend into the fourth wave of COVID-19 in South Africa, we appreciate that an overly individualized model of care may reinforce the shame felt by doctors who believe that they are not coping. The key issue is at stake is not the mental health of individual doctors, not that this is not important or a trivial concern, but in the ways in which the work and organizational dynamics may be changed to support doctors and normalize their experiences. Other authors have suggested that a peer support model, as opposed to a mental health model, may be a more appropriate way to support clinicians during COVID-19, and we agree with this. There is, in addition, a set of contextual realities which make this approach more crucial in a highly stressed health system in a country like South Africa. Participants in our group noted how, unlike colleagues in wealthier countries, they were accustomed to making very difficult triage decisions based on lack of resources, and to some extent, the experience of not being able to help all patients was nothing new. This history, as well as the history of being clinicians working at the epicenter of the HIV/AIDS pandemic, paradoxically, seems to have been experienced as protective by our colleagues. The South African healthcare system was routinely described as stressed before COVID-19. Some of our colleagues, for some of them, the pandemic accessed memories of working during the early days of the HIV epidemic prior to access of antiretroviral therapy. Healthcare systems around the world have been traumatized and overwhelmed during the pandemic. But the burden on a system like that in South Africa is objectively higher. But paradoxically, this made our colleagues feel more prepared for the pandemic than they might otherwise have done. But the pandemic has raised questions about the way in which clinicians deal with the ongoing experience of working in very stressed and under-resourced health systems. We believe our work with our colleagues has been helpful, and the feedback we have received has been positive. But the experience has given us a window into longer-term questions regarding the well-being of doctors in an under-resourced healthcare system in a violent and unequal country. These doctors deal with and embody the consequences of a society which is not healthy. Many commentators globally have argued that the COVID-19 pandemic has exposed existing global and local inequities and deprivations. As most countries in Africa are in the risk groups for vaccine inaccessibility and therefore likely to be entering a fourth wave of the pandemic in the coming weeks, supporting healthcare workers in low middle income countries remains a priority. Our solution to supporting doctors in a traumatized system faced with the pandemic was not found in traditional mental health interventions, but in the power of shared trauma. Our description of a collegial-based intervention argues for the importance of integrating mental health professionals within COVID-19 frontline teams, thereby facilitating a basis of trust and shared experiences, which shifts the model of supporting our colleagues in a traditional group therapy model to a collegial support space. Key issues this model addresses are the stigmatization in medical culture of uncertainty, perception of vulnerability as failure, and shame for needing support. Collegial interventions also provide relief from isolation, and which can be a feature of trauma. Intrinsic to the model is flattening of the medical hierarchy and the creation of a collegial team, including psychiatry and psychology, all contributing to the same service and experiencing the same trauma. I'd just like to acknowledge all of the healthcare workers at Groote Schuur Hospital that I've had the privilege to work with during the COVID-19 pandemic. Thank you.
Hello everyone, I'm Graham and thank you for the opportunity to talk today. I'm going to present on a qualitative study that was done across the country. I'm presenting on behalf of a large team, and thank you to them. You'll notice that many of them are from USAID or from the PanAgora group directly, and really I was only there as a technical advisor, and this is all their work and credit to them. So why did we conduct the study? So as we all know, there was a severe COVID outbreak, and as just mentioned, we were especially worried about the consequences of that in exacerbating existing HIV and TB epidemics. And amongst USAID implementing partners, so these are organizations funded by the USAID to support the Department of Health in implementing HIV TB care. They received reports through their various channels that health workers employed by them to provide that support were distressed at the peak of the first wave. And so really this was in response to that, and it is a study only amongst USAID implementing partners, but we suggest has implications for the health system more broadly. When did we do the study? So as I say, mid-year 2020, we were in the middle of the first wave and received this note of distress and various reports that health workers weren't coping. This is a phase of planning and inception and receiving ethics clearance. We then prepared for fieldwork toward the end of last year and really collected data at the beginning of this year and completed that by mid-year and have begun the process of dissemination. What was our goal? So it was to explore the mental health experiences of health workers during the epidemic, and it was in 7 high-burden HIV and TB provinces. So those are the 7 provinces where USAID implementing partners work. Pragmatically, we wanted to determine what support is needed so that health workers could better cope, but also to assess what resources are available to support that and how those need to be supplemented, if at all. A note that when we think about mental health, it's really about holistic mental well-being, which is a dynamic concept that includes the ability to cope with stresses. As just mentioned, being a health worker is very stressful for a variety of reasons. And then to display that healthy behavior, to perform roles at work, but also in your home, family, and community that are adaptive and good for you and those around you. What did we do? So there was quite an extensive consultation with the implementing partners, with researchers, and actually with some health workers themselves about how best to understand health workers' perspectives and co-develop appropriate interventions. And we settled on qualitative data with the purpose of sampling of participants working within the USAID implementing partner framework. There was a deductive logic to what we were trying to achieve, in that we were trying to come up with solutions or practical guides within the USAID implementing partner frameworks. And so the research design was exploratory, descriptive, and pragmatic. We did data collection through in-depth semi-structured interviews, which were conducted remotely. We stopped recruitment when there was data saturation, and then we organized those data thematically in vivo. And we analyzed it by producing case descriptions of each participant, each health worker's experience, their overall experience, and then we compared between those case descriptions, looking for common things, and then also people who had slightly different experiences. The study received ethical approval from Stellenbosch University and from the district and provincial DRH offices in each of the places we implemented, and all participants signed written informed consent, were provided information on mental health counselling and social services support, and received 150 Rand support in order to access the place where we conducted the interview. So we would use a venue, and even though the interviews were conducted remotely using Zoom or similar, many of the health workers had to come from their field locations to an office, and that office included costs. So that's what the reimbursement was for. And they were given information and PPE to protect them and so on. Where did we do the study? So there's a list of the implementing partners there named, but as I say, across 7 different provinces and in a number of different districts. The participants were grouped as either urban, peri-urban, rural, and there was broadly equal representation across those categories. Most of the participants were women. This is a total of just under 100 participants. There were men who participated, but this broadly reflects the number of, or the proportion of women as health workers in the country and for these implementing partners. Similarly, the age distribution was as expected, and we included people at entry level, mid-level, and a kind of upper level programming, but also people implementing services directly or also in administrative and operational support. So what did we find? Overall, that the implementing partners are already offering a package of mental health services. Now, this varies by implementing partner, but they all had systems in place. But the health workers at both facilities and community-based experience barriers to accessing those services. So what we really needed to do was find ways to create a facilitating or enabling environment so that people could take up that mental health support. And our recommendation is that the interventions or the things that are being done to provide mental health support are appropriate in the context, but they need operationalization to facilitate actual implementation and uptake. Broadly, there were 4 groups of findings arranged in the rows here. The first group of findings are what was it like to be a health worker during COVID, and many of us have these understandings. But briefly, there were 3 themes. There was health workers experienced a range of extreme emotions: despair, despondency, feeling like things were slightly hopeless at times, and this changed each day. But there are unhealthy emotions in this given context. Many health workers also reported feeling guilty for not being able to continue to provide quality care to their clients. And so, for example, health workers who were perhaps the community health worker delivering services to a family where a child, she knew that not being able to provide that ongoing support meant one of the children in that family may go hungry or similar. So they felt a lot of guilt about not being able to do it. And at the same time, quite a lot of fear about acquiring COVID. And this was even though we were well into 2021 and had a clear understanding of how to protect oneself and so on. In terms of coping, was important to note that there were quite limited coping mechanisms amongst health workers. We asked them specifically, what do you do to relieve stress? How do you manage the difficult things that you experience? Very few people talked about talking to others, including, as just mentioned, loved ones or partners and so on. Very few reported accessing any counseling or mental health support themselves. Some reported things like, distractions, watching Netflix and similar. Some reported quite unhealthy things like drinking a lot. But there was overall a sense that one just had to be strong as a health worker and maybe pray and hope it gets better, but overall not proactive seeking out of ways to manage stresses. And particularly the ideas that regardless of what culture the participants identified as and what gender they identified as, they all presented those as barriers. So men said that men don't access mental health support because they're men, and women said the same thing because they're women, and so on. So all of those things. Having said that, even though there were all of these challenges and not clear coping mechanisms, there was also a lot of resilience and adaptability amongst health workers. So essentially, people would push themselves beyond the pale until they break, in inverted commas. In terms of what additional support was needed, so there was, I'll start at the bottom of these three bullets in the third row here. There was some acknowledgement that some health workers would experience either problem drinking or depression and similar, and that they needed support and referral for those mental health disorders. And often those existed, and the health workers just didn't know about the pathways or didn't have appropriate support to access those. Moving up in this in this row, the second kind of category of need, or what additional support that was needed, was that people experience stressor events. So if you go into the community as a community health worker and you witness extreme violence, even if you can cope with that, it's a stressor event which isn't actually about you and your work, but it's something that you experience as part of your work. And you needed to go through some process to decompress, experience that, and work through it. A little bit like if you're a police officer and you discharge your firearm, even if someone isn't hurt by that, it's routine practice to then go through a process of counseling or similar, just to manage that experience. So this was really a gap that people didn't consider the available services, even though they could be used for this. People didn't think that the available services met this or would actually be available or could be for if you just experience something which is quite stressful as part of your work. And then the third category, which is the first here, is that just every day life is really stressful as a health worker, and there's an everyday burden. And so everyday things need to be done to help health workers manage that. Linked to that, in our last set of findings, we also spoke to supervisors or management staff, and they really spoke about the need to appreciate staff for all the hard work more, so that that burden is acknowledged, and it's not felt like people are alone and just have to get on with it and chase targets. But also for themselves as managers, that if they didn't know how to cope or help a staff member, that they could access additional mental health support and how to do that. So the next set of findings is just to acknowledge that all groups along the cascade, everyone involved in the organization has a role to play. So this included health workers themselves in acknowledging their mental health needs, speaking up when they needed something, and accessing the services. Particularly important was healthcare workers, supervisors at the kind of micro level that needed to incorporate mental health support into routine meetings and making mental health support and recognition and mentoring and linking to care part of every day. If you're having a weekly meeting, it's always on the agenda and similar. For the HR staff and program managers, it was to ensure, particularly at onboarding, when new staff are hired and as part of routine annual support, to make sure that mental health awareness and how to access services was made available. including as part of workplace wellness programs, from the leadership to ensure that mental health information, resources, and services are disseminated and really championed throughout the organization, and that's with the direct support, as I said, within the context of USAID. I'm just broadly going to say as a last thing, and these resources are available, and I'm sure that the team will share the link shortly again if they haven't already. We identified 5 areas of tools, toolkits, and resources, and each of these toolkits and resources has a problem statement, a context in which you might use it, a recommendation, what you will do, who should facilitate it, how much effort it should take, time and person, what resources are included, and tools that if they're part of that recommendation. And they were in the context of in-service training around mental health and accessing mental health support, routine meetings, how to recognize staff and awards, supportive supervision, and how to create a healthy workplace. So those 5 core areas have been broken down into a set of tools. As I say, those are available. I'm just going to give a quick example of the first here. So if we're talking about in-service training, we identified 4 types of things that people needed in-service training on. The first might be on mental health and the support available. The next might be on the different types of mental health support needs, whether it's referral for a disorder or a challenge, or daily recognition, and similarly. And for each of those have provided, usually it's a PowerPoint presentation template, and then it's some content on mental health and similar, and a tool and a set of resources. So these have been disseminated within the context of the USAID implementing partners for the use and adaptation within their local context, but are also available through this dissemination to whoever wants to take them up. And please do be in contact. So just to say, they're on all 5 of those areas. And please do be, thank you, and do be in contact if you want any support on how to use those or just contextualization. Thank you.
Thank you so much. I'm not sure if I'm on. I am back on. Thank you so much to our panelists for the rich conversations, but also very, very worrying. And just hearing about the extent of COVID and the impact on health providers more than we ever imagined when we talk about these things, and hearing from real voices has really heightened the extent of the impact of the pandemic on our frontline providers. So I was going to summarize, but I'm not going to do that in the interest of time. I'd really, really would like to throw a few questions to our panelists. There are some questions in the chat box. If you're able to answer them, please reply in the chat box, in the Q&A box. I had a question for each panelist. My first one was to Dr. Fileuka. As a frontline health provider, what would your message be to other health providers on this platform, in this summit, in terms of what can be done at local and clinic level to care for health providers better than we're currently doing? And how can we integrate mechanisms that care and support our health providers and community workers? My next question is to Shanae, Bongiwe, and Bulelwa. I really wanted to hear whether there was anything specific in the nurses' experience or from listening to the nurses, what stood out for you as researchers during these interviews, and what would your comments be on that? I know you've given some broad recommendations, but I really would like to hear about your interactions and what your personal takeaways from that were. And then my next question is to Dr. Ohodinot, and in your work exploring debriefing platforms, I wanted to find out whether there's anything that stood out, one specific debriefing platform, one or two, that stood out that you could share an example with us, and that may be easily adaptable by other teams anywhere in the region. So if you do, I really look forward to hear that. And then my last question is to Professor Ho. I really applaud your approach on going in and really listening and understanding what kind of support and how your teams and peers wanted their support in a way that is meaningful to them. And thank you as well for sharing your personal story. So given all the challenges that my question is that given all the challenges that health providers face, some of them are systemic, what do you think, and let's think broadly beyond South Africa, because I think South Africa, we're in a better place than some of the countries in the continent. What do you think needs to be done at health systems level and by who to make sure that health providers' well-being is the most basic right is prioritized and protected? Thank you. So if we could start with Dr. Fileoka, if I could say 2 minutes, please, to each speaker so that we might be able to go through some of the questions in the Q&A. Over to you, Dr. Fileoka.
Yes, thank you very much. For the question, first of all, I just want to acknowledge the work and for the healthcare workers who have been frontlining on this COVID-19 pandemic. And I really, really salute you. And the thing is, working as a healthcare provider, sometimes it put us in a situation where sharing your weakness, sharing of being overwhelmed, sharing of being burnout is something like it's something that you feel that you're weak, as even Professor Jackie was saying, like you feel weak, you feel like you are not, you feel guilt that you're not being able to perform or to support your clients. But looking on the other side is not sharing might have also burden you and ended up with burnout or any other mental health challenges as well. So what I encourage you to healthcare providers is to create some spaces, like safe space, whether at the clinic, whether during gathering or in any social media, because I know most of healthcare providers have one form of social media groups that they can share, even through WhatsApp or Instagram or whatever, but they can share with that. So just, you can use that as a platform to vent and also encourage other people to also share their story as well and do the debriefing. Working in the environment in sub-Saharan Africa our facilities are heavy, it's busy, and also we are resource limited, and we may not have time to sit and discuss these issues. That's why I'm encouraging even other platform can be useful for safe space and just to speak out in an informal way, and also encouraging even the CBOs to create that environment for healthcare providers. And further to that is, we understand most of our facilities have clinical meetings on a weekly basis or on a daily basis, but we can use even one clinical meeting to just use that part to vent and to share our experiences, to talk about our burden, and that could be a relief as well. And I understand we are lacking human resource in mental health. And,
thank you, Dr. Fileoka. I'm sorry, I'm going to have to cut you off because we really have very little time, and I'd really like to hear from the other panelists. Shane, Babalwa, and Bulelwa, please can you respond to your question? Thank you.
Just to confirm that it's Shane, Babalwa, and Bongi. Thank you, Agnes.
Apologies.
No worries. I've been gently nudged to speak on behalf of the team. I think what was so clear throughout the interview process was this heaviness and the sense of distress that was really palpable in every single interview coming from the nurses. This idea, something that really stuck out, I think in all of our debrief sessions is this feeling that the pandemic was almost bleeding into every element of the nurse's reality, whether it was at work, whether it was home, social life, daily life. There was no break. Having that ability to somewhat separate home and work, that was completely gone. That combination of factors was something that was clear in every single interview, and the adjustments that the nurses had to make in response to the fear and anxiety and worry caused by those combination of spaces. I think that was something that we had multiple debrief sessions over, trying to just process for ourselves, never mind thinking about what the nurses were going through. That was something that stuck, I think, with all of us. I'm not sure if you guys agree. Yes. It was definitely the realities of their challenges, going beyond logistics, going beyond the practical, but this kind of moral element as well. Did we stick to your 2 minutes?
Perfect. Thank you so much. And then the next, I think it was Dr. Jackie was next, and then Dr. Hodinot. Please go ahead, Jackie. Thank you.
Hi there. So I think the most important intervention in terms of supporting healthcare workers is the acknowledgement that they are the most valuable resource in the healthcare system. And they need to be cared for as though they're the most valuable resource in the healthcare system. So I suppose Groote Schuur, we got better at it over time, and by the time the third wave happened, which we've just exited, we had a sort of a whole hospital response in terms of, trying to manage the COVID service. The healthcare systems need to acknowledge the enormous trauma, and they need to protect the amount of time and the number of hours that people are on the COVID floor. I mean, that's incredibly important. But again, obviously always more challenging in countries where medical professionals are more limited. But the idea of a whole hospital response was an incredibly, it certainly mitigated some of the trauma that happened in the second wave, where the Department of Medicine carried the burden because it's a medical condition. The doctors and healthcare workers, they spent too much time in those wards. They needed a break. By sort of pooling and getting resources from other departments, obs and gynae, oncology, etc., we were able to reduce the number of days exposed to the trauma. I mean, I think that's incredibly important. And the other thing that's really important is limiting the number of working hours, because the more fatigued you are, the more likely you are to have burnout and develop mental health problems. So that was certainly incredibly important. And the other thing is the power of teams. Keeping the same people together. I mean, as I tried to explain in my talk, while trauma isolates you from those who haven't experienced the same things, it does band you together, those who are experiencing the same things. And we realized, the importance in developing. So we had like small teams who were kind of used to working together, and those teams stayed units, kind of working together in the third wave. And those relationships, that kind of sense of trust, and those are incredibly important interventions. So I think it's about having a look at all the resources you have and really trying to think out of the box about how you can protect all healthcare workers, restructuring services, getting surgeons involved, getting everybody involved from all around the hospital. I mean, yes, there were issues in that because, of course, it's a medical condition, not a surgical condition. So many people felt like, well, I don't know what I'm going to, I feel a bit overwhelmed. I'm not sure I can manage this, but again, we balanced the team. So there would be surgeons with medics, or people who had lots of COVID experience with people who had little COVID experience. And so we kind of tried to balance those things out in terms of, kind of forming these teams. But teams are incredibly important. Thanks.
Thank you. Thank you so much. And for me, if there is one thing out of all the recommendations that you've given, one thing that's in our control is the teamwork, is the peerness. And and you've just really demonstrated how, as I said earlier, the power of peer support. And when you're speaking to someone who's really walked the journey and understands what you're going through. So thank you for that. And then Dr. Hoddinott, please, could you respond to the last question? And if you could please respond in the chat box. And then one more request for those who are listening, please, could you post the one thing that you've taken away from this session? If you could post in the chat box, what you think you're going to take away and try and implement when you go back to your facility. Over to you, Dr. Hoddinott. Apologies for that.
No problem. So I just briefly want to share a screen, actually. So I think it's really important to recognize that actually a lot of what health workers in our study were showing is it's COVID, but it's also pre-COVID and it's post-COVID, that if you're going to deliver quality care to clients, you have to be well yourself. And that includes managing your mental wellness. And so mental health of health workers shouldn't be framed as a remedial thing that you address if there's an issue, but rather should be central to everything that is done so that the health workers are as optimum tools of health services as possible. And so a lot of what we would recommend, you asked for a particular tool or way of debriefing, I think it has to be integrated across everything. So I am sharing a tool that we have, and this is part of the toolkit that you can use, but I think with that caveat, located within a whole-scale reimagining of mental well-being of health workers as core to quality service delivery. So this is a template which we've provided, which we think would take like an hour-long workshop facilitated internally by maybe someone from HR and the manager or the supervisor, depending on the level of the team. And it's really to raise awareness of the fact that mental health needs aren't only for when you have a mental health breakdown or challenge, but rather are every day. And so here's a set of tools which the person would adapt, or the user would adapt, where you stay what the objectives are. You talk through this in about 10 to 15 minutes, and in it, there are activities to discuss. So this is just to say that there are these 3 different levels to mental health support needs: functioning, opening, managing stressful events, and so on. You set some ground rules, and then you do some recap and give some information on what is mental health and well-being and how does it fit into a program. Some resources about how COVID has impacted on that to kind of locate it. And then you have a discussion within the team, which is facilitated around these questions of, why is it important for health workers to be healthy, and what kind of support do people need? And then you kind of just guide people through this conversation of thinking through what do we need to function optimally? What do we need to manage a stressful event? What do we need if we're managing a chronic mental health support? And you do this in groups at the level of teams to, as I say, foreground and make mental well-being central to everything that is done. And it's just I'm going to stop there in the interest of time, but here are a set of resources and so on.
Thank you so much. And again, a huge thank you to all our panelists. We've gone over time. I think we were a little ambitious to think that we can have this kind of conversation in the time that we had. I mean, I feel I'm walking away with a terrible sense of we've only scratched the surface, and what does that help? So so thank you. I'm hoping that we as PATA will be able to create another platform to carry on with these conversations so we can support our health providers across the region. But thank you so much to all our speakers, and I will definitely be getting in touch for next steps.